I'm Adrienne Brigido, Director of Nurse Education for Springer Publishing Company. Thank you for joining us today for a webinar on best practices in evidence-based health and assessment. The webinar will be presented by Bernadette Mazurek-Melnick, Kate Sustersik-Golick, and Alice M. Teal from the College of Nursing at The Ohio State University. They are editors of the groundbreaking new textbook and comprehensive learning resource, Best Practices for Health and Wellbeing Assessment. At the end of this webinar, you'll receive a survey in which you'll have the option to request a desk copy of their new textbook, which we certainly hope you will do. Bernadette Melnick is Vice President for Health Promotion, University Chief Wellness Officer, and Professor and Dean of the College of Nursing. She is also Executive Director of the Helene Fold Health Trust National Institute for Evidence-Based Practice in Nursing and Healthcare, and is an internationally recognized expert in evidence-based practice, intervention research, child and adolescent mental health, and health and wellness. She has consulted with healthcare systems and colleges worldwide on how to improve quality and care and patient outcomes through evidence-based practice. Kate Golick is Assistant Professor of Clinical Nursing and a Certified Adult and Family Nurse Practitioner. Dr. Golick's areas of expertise include evidence-based practice, population health, preventive medicine, wellness, and clinician well-being. She is the project manager for the Million Hearts Initiative at the College of Nursing and serves on state and national work groups targeted at improving cardiovascular population health. Alice Teal is the Director of Graduate Health and Wellness Programming, Director of Innovative Telehealth Services, and Assistant Professor of Clinical Nursing. Dr. Teal is certified as a family and pediatric nurse practitioner and integrative nurse coach. Her areas of expertise include adolescent health, primary care of at-risk youth and families, college health, and recovery from substance use disorder. Dr. Teal serves on statewide initiatives to improve access to care using telehealth technologies. We will try to address any questions you have at the end of the presentation, so please feel free to submit throughout. Without further ado, I will turn the presentation over to Dr. Melnick, who will begin by making the case for evidence-based assessment.
Thank you. I am super excited to be with you today with my wonderful colleagues and faculty, Kate and Alice. And I have to tell you how this all came about. So over a year ago, Kate, who I work very closely with, especially on our Million Hearts Initiative, came into my office and said, Bern, we need to write a cutting-edge book on evidence-based assessment because there's still too many outdated practices that exist all over the country. And of course, those of you who know me and my work, I'm a passionate fanatic about evidence-based practice. And of course I said, yes, let's do it. So we are really excited about this webinar. We want to give you a bird's eye look at why this is such a key area for our practicing folks as well as for our students. I have long had the philosophy, in God we trust, but everybody else better bring data to the table. And seriously, we live by that philosophy here at Ohio State. We're going to be calling your attention to so many practices that are not based on evidence, that are still being promoted in health assessment courses and clinical practice settings. I always tell people evidence-based practice plus clinician well-being equals the quadruple aim in healthcare. The triple aim came about years ago by the Institute for Healthcare Improvement, and that involved enhancing the patient experience. That includes healthcare quality and safety, improving population health outcomes, decreasing costs. But then a few years ago, there was a landmark paper published, and the authors of that paper said, wait a minute, we are missing one important aim, and that is the aim of improving the work life and well-being of healthcare providers. So what is another element of our book that is so unique to every other physical exam and assessment text? We have a whole chapter devoted to the health and well-being of us, the clinician. I'll talk more at the end of the presentation about the National Academy of Medicine's Action Collaborative on clinician well-being and resilience. Well, we spend more money on healthcare than any Western world country. Despite that, we have terrible health outcomes. Heart disease, which is 80% preventable with healthy lifestyle behaviors, is still the #1 cause of death for both men and women in this country, followed by cancer, and very shockingly, medical errors. Medical errors are the 3rd leading cause of death in America, often as a result of very conscientious, well-meaning clinicians who are unfortunately burnt out, plumb exhausted, depressed. So we have so much work to do around this whole area, again, in improving clinician well-being. I'll never forget where I was when I saw these news headlines. 700 moms die each year in childbirth, many of them needlessly, because we are not following evidence-based assessments and practices. We are actually the worst Western world country to give birth in, and we must turn this around urgently. Poor quality healthcare costs the United States billions of dollars every single year. Wasteful healthcare spending, because so often clinicians are over-screening or they're not following current evidence-based practices and guidelines. We could decrease our U.S. healthcare system costs drastically if more clinicians practice great evidence-based assessment and evidence-based management. I wish I had more time to share my youngest daughter's story with all of you. Kaylin almost died over a decade ago in Australia due to non-evidence-based healthcare. A ruptured appendix that resulted in full-blown peritonitis, pelvic sepsis, bacteremia, and early septicemia. Even though I advocated furiously, I was not listened to, the data on assessment was not evidence-based. I will never forget the day Kaylin was in an emergency room in Cairns, Australia, and a physician over there had her jumping up and down on her right foot, saying when a child can do this burn, they don't have an abdominal issue, even though I knew she had early appendicitis. I advocated like crazy, but nobody would listen to me. I said to that physician, where's the evidence on the jump on the right foot test? Because we don't do that with children in the United States. Bottom line is, if I wasn't a seasoned nurse practitioner who advocated aggressively for a simple ultrasound for my daughter, Kaylin would have died. One of the happiest days in my life as a mom was giving Kaylin her diploma from veterinary medical school with the dean of VetNet here at Ohio State this past May. So again, my own personal stories from my own life, but thousands of people across the United States create a passion in me to continue to bang the drum on evidence-based assessment and healthcare. We know when clinicians combine research, high-quality studies with their clinical expertise, good assessments, and patients' preferences and values, they make the best decisions that lead to the best outcomes. We can, and we do, here at Ohio State, teach our students to be steeped in evidence-based practice. But if they enter a culture, a clinical environment where that is not the norm, they're going to slip back with those evidence-based practice skills. We have so much opportunity to improve evidence-based assessment, decision-making, and management across the United States. But we shouldn't argue about this anymore. We have so much research to show when we deliver evidence-based practice, patient outcomes are at least 30% better. But despite all this wonderful research that we have, so little of it gets translated in the clinical practice to improve outcomes. We have this saying, it takes 17 years to translate evidence into practice. I say that is if you're blessed and lucky, because most times it takes 30, 40, or 50 years to change practice based on best evidence. When did we say all RNs will have bachelor's degrees? That was back in '65. It is 55 years, and we have so many states across the country that still only have 30 to 40% baccalaureate prepared nursing. So despite the knowledge, despite the evidence on how to screen, how to conduct evidence-based assessments, we still have non-evidence-based practices occurring all throughout the United States. This is a true life example. The tongue patch for weight loss. This is a procedure being conducted by a surgeon who was featured on a national news story. He sews nubby little plastic patches on the anterior of people's tongue with 6 stitches to encourage them to lose weight. This surgeon was interviewed, you can Google it, on national TV. A reporter asked the surgeon, "What evidence do you have behind this tongue patch?" The surgeon said, "Well, I have anecdotal evidence this is working for the women I'm doing this procedure on." That reporter asked, "Well, how does it work?" This is the honest to goodness answer that he gave. He said it creates so much pain for anybody to swallow anything but liquid. It's like a behavioral modification device. What is the definition of insanity? I think this is an extremely good example of that. So many of you that are on the webinar today, you as faculty may be teaching assessment to your students, and maybe for a really long time. And we know it's tough to make a change, especially after all course materials are developed and we have everything down packed. But we are urging you today to really take a look at the best evidence and the best practices, and to teach those best evidence-based assessment practices to your students. We all know, though, the only person who likes change is a baby with a wet diaper. We realize change is what I call character building, but you have got to help us to implement more evidence-based assessment and practice throughout the United States. I'm going to turn it over now to my wonderful colleague and faculty, Kate Golick, who is going to talk about some of the outdated practices that we continue to teach without the best evidence.
Thank you so much, Bern. So my name is Kate Golick, and that was a great introduction to evidence-based practice. And I am now going to talk to you about 3 examples of assessment techniques that are still commonly taught to many of our health sciences students. And we're going to talk about the evidence around these 3 methods. So first, let's talk about auscultating vowel sounds. So I want you to think about a common practice like this. So auscultation is really part of any abdominal exam. So when we think about vowel sounds, we need to ask the questions. First, why are we listening for vowel sounds? What is the evidence supporting listening to vowel sounds? And what is the evidence on pathological variations with vowel sounds? So the major obstacles when assessing these vowel sounds lies in the fact that there is an absence of standards and an overall lack of evidence supporting their usefulness when we're assessing patients. So auscultating vowel sounds generally has been thought to provide information about vowel motility and vowel function. Current resources will state that vowel sounds occur anywhere from 5 to 34 times per minute, and they're typically described as high-pitched gurgling noises. So even in thinking about this frequency range, this is a very large frequency range, and this can make it very hard to identify and then classify what's hypoactive, what's hyperactive, typically how we talk about vowel sounds. And additionally, we don't know what the patient's baselines are. So more importantly, there's currently no evidence saying that this is the normal range. So then let's think about why we listen to them. So many of us are performing them during every abdominal exam. But again, what kind of information is that giving us? And from an evidence standpoint, you have to think, what evidence is there that this assessment is making a positive difference to our patients, right? Because there's no evidence that bowel sounds are diagnostic really to any condition. Many of the studies that are currently available that discuss bowel sounds, they look specifically at their clinical usefulness in two areas. So in those patients with suspected bowel obstruction and in those patients who've undergone some kind of abdominal surgery and they're looking for the return of the gastrointestinal motility. But even for these two conditions, in the very small number of research studies that are available on this, they found that auscultating bowel sounds is not a useful clinical practice when differentiating patients with normal versus pathological diagnoses. There's also very low accuracy and intra-observer agreement due to this lack of an objective gold standard in which to measure and then correlate bowel sounds to a clinical diagnosis. So when we're looking specifically at sensitivity and positive predictive value, you can see here how low these are. So 32% and then 23% respectively in healthy people, 22 and 28 in obstructive ileus, and then 22 and 44% in postoperative ileus. And I did also find a study where they looked at that patient outcomes of patients they assessed that had bowel sounds, or when the nurses actually auscultated bowel sounds post-surgery and when they did not, and the outcomes were the same. So to answer our original clinical question, auscultating bowel sounds in clinical practice is not useful. There's low sensitivity, low positive predictive value, and then that poor inter and intra-rater agreement. So the next technique that I'm going to talk about is the percussion of the diaphragmatic excursion. So if you remember, this is when the clinician estimates the range of the diaphragm movement using the percussion technique. So this is where the clinician asks the patient to take a full inspiration and hold it, then determines the lowest margin of resonance by percussing over the lower lung fields and moving downward in small increments until they hear a change in the percussion note. And then the patient's instructed to exhale fully and hold that position while that same percussion procedure is repeated. And then that's supposed to be measured, and a normal measurement is supposed to be between 5 and 7 centimeters. So if you teach assessment, you're probably aware of this part of the respiratory assessment. This is commonly taught in assessment courses, but it's never really used in clinical practice. And this is actually for a very good reason too. When we started looking at the evidence, and I think you're all going to laugh at this, we only found 2 studies looking at the clinical usefulness of this maneuver. One was from 1981, and one was from 1982. So again, to go back to Bern's point, this is 40 years later. Both of those studies came to the conclusion that percussion of diaphragmatic excursion should not be used in practice. And these statistics that I have on here came from one of those papers. So this is the Cohen's kappa coefficient, or that's the inter-rater reliability, and that's in the negatives, so negative 0.04. And then the correlation coefficient R, and that's also very, very low. So why are we still teaching this? Similar to a lot of our other clinical examination techniques, we continue to teach this because we always have done it that way. And because it's included still in a lot of assessment textbooks. So hopefully this has just persuaded you, if you are an educator or a very unusual clinician that is doing this in practice, to stop teaching and doing this maneuver. The last technique I'm going to highlight is to discuss the use of fundoscopy in the primary care setting. So this is something that we teach to all students during assessment. And I still, to this day, remember being a student and doing a fundoscopy exam for the first time. I'm so excited. I have, looking in my partner's eye, and I envision seeing exactly what's in the book, that perfect round circle with the macula and the optic nerve. But as you all know, you see a teeny tiny small field of view when the eye is undilated, despite the high magnification that you're using. And we know that when experts complete this exam undilated, it's even difficult for them. And this isn't something where we would change practice. Dilating the eye in primary care settings also has risks. It can do things like precipitate acute angle closure glaucoma in certain individuals, and it's unsafe, obviously in pediatrics. So what is the evidence? So individuals who are at high risk for retinopathy benefit from vision screenings. So here, we're talking about individuals with hypertension, diabetes, or any diseases that have associated ocular symptoms. And they need a comprehensive dilated examination by an eye specialist, so an ophthalmologist or an optometrist. And if no evidence of retinopathy for one or more of the annual eye exams occurs, then exams every 2 years can be considered, but typically they're completed yearly in these individuals. So why is this important to what we're teaching our students? Well, an undilated fundoscopy exam is completed in the office. When an undilated fundoscopy exam is completed in the office by a clinician who's not a specialist, the patient often gets very confused and they think they've had an exam. And so then they forego the specialist evaluation with a dilated eye exam. So the consequences of this, are that these recommended dilated eye exams aren't happening for these at-risk populations, and this can lead to significant vision loss later on because things aren't caught. So this really needs to be communicated with our students that they need to defer this exam to the specialists, especially in these high-risk populations. So these are just 3 examples of how assessment needs to be updated, and it needs to be more in alignment with the evidence that's out there. So this is an area that greatly needs more research, and much of our current research is very old and it's of very low quality. The problem in doing these types of studies is often due to the rater's experience and training status. They can have major impact on reliability results and the ability to generalize to other populations. These results are also often limited due to things like heterogeneity, low quality studies, and small sample sizes. Physical therapy has actually probably done the best job at producing high quality studies and meta-analyses that look specifically at the musculoskeletal exams. But much of the research on these exams points that combinations of these tests can provide better accuracy. So that translates to other areas of assessment as well. But the bottom line is more large, high quality studies are needed in the area of physical assessment. But I will end with this by saying that there's also a lot of research that the context and the quality of the bedside examination are associated with neurobiological changes in the patient, showing a positive therapeutic effect. So patients really expect that some form of examination will take place when they see a clinician, and when a clinician completes an exam in a very expert and engaged manner, it really can have a beneficial effect. On the contrary, if an exam is done, it's not done at all, or it's done very poorly, it can undermine that clinician-patient relationship as well as the final diagnosis. Technology can't restore our professional satisfaction, and it's not the unique and acceptable resource for clinicians to meet the whole expectations of our patients. But the physical exam really is an essential piece to practice for so many different reasons. It is just so important to ensure that we, as clinicians, as educators, are incorporating the best evidence to ensure the highest quality and best outcomes for our patients and students. So I will now pass it to Dr. Alice Teal to talk about the mental health assessment.
Okay, hello, this is Alice Teal, and I want to thank my colleagues Bern Milnick and Kate Golick, and note that as listeners to this webinar, you may be appreciating that our newly published text with Springer Publishing was a result of our passion to teach and implement evidence-based practice. This includes clarifying the importance of incorporating mental health assessments into all assessments of health and well-being. And to reach this aim, there are individual chapters of our new text addressing evidence-based assessment of mental health, substance use, trauma, and the therapeutic communication skills required to be effective when incorporating mental health into all assessments. So in 1999, the US Surgeon General David Satcher went on the record as the first Surgeon General to issue a report on mental health and illness. And at the time, he stated, "There is no health without mental health." And the evidence continues to support this truth. 1 in 5 adults experience mental illness each year. Suicide is the second leading cause of death for 10 to 34-year-olds. And about 1 in 5 adults with a mental illness have a co-occurring substance use disorder. Yet less than 11% of those adults with substance use disorder receive treatment. And less than half of adults with mental illness receive treatment. The average delay, for those who do receive treatment, the average delay between onset and treatment is 11 years. And we know that individuals with depression have a higher risk of developing cardiovascular and metabolic diseases. And the reverse is also true, that individuals with chronic diseases like heart disease are more likely to have co-occurring mental health disorders. So for positive health and wellness outcomes, we need to assess mental health and screen for mental health disorders. The United States Preventive Services Task Force, the USPSTF, has established evidence-based recommendations screening for all adolescents and adults. These include screening 12 to 18-year-olds routinely for depression. And note that depression screening includes assessing for suicidal ideation, that screening does not heighten risk. And in their recommendations for routine screening of adults, the USPSTF specifically notes that populations at high risk, with women who are pregnant or postpartum, should be screened for depression, and women of reproductive age should be screened for intimate partner violence. The evidence-based guidelines for routine screening for tobacco use, alcohol misuse, and illicit drug use are summarized on this slide. The USPSTF new guidelines regarding screening for illicit drug use are actually in draft form and are currently open for comment. So to meet these evidence-based guidelines, we recommend using evidence-based screening tools. The PHQ-2 and the PHQ-9 screen for depression. The PHQ-2, comprising the first 2 items of the PHQ-9, inquires about the degree to which an individual has experienced depressed mood and anhedonia over the past 2 weeks. So individuals who screen positively with the PHQ-2 should be further evaluated with the PHQ-9 to determine whether they meet the criteria for depressive disorders. The GAD-2 and the GAD-7 are screening tools for anxiety. The GAD-2 is very brief. It's easy to perform initial screening tool for generalized anxiety disorder with a sensitivity of 86% and specificity for 83% for the diagnosis. So as students learn these tools and as we implement these tools, it's imperative that we also use the skills and strategies needed to create trust, to communicate empathy, to coach wellness. And a chapter of our text reviews those therapeutic communication skills as well as motivational interviewing. For novice clinicians and for students, incorporating comprehensive mental status and mental health assessments into all assessments is a challenge. One of the mnemonics in our text that's intended to be helpful is simply ABC. So in the same way that we learn to assess with ABCs for physiologic stability, right? Airway, breathing, circulation, we can learn to do assessments of mental health with ABC. Appearance, behavior, and cognition. How do they appear? How is someone behaving? What are they telling us that gives us insight into their thought processes? In addition, our text has an entire chapter addressing substance use disorder. This increased focus is for a number of reasons, and these include the current crises related to vaping, respiratory illnesses, as well as the opioid epidemic. The map on this slide depicts the opioid-involved overdose deaths from 2017. And we are presenting this webinar today from Ohio, which has been the epicenter of this crisis. We recognize that there is professional and, how do I say this? We recognize the professional and personal significance of substance misuse and substance use disorder, because what we know, even without seeing you, we recognize that 1 in 3 Americans are directly affected by addiction. And that certainly includes healthcare providers and clinicians. Substance use disorder is a chronic illness difficult to treat and prone to relapse. It's defined as a problematic pattern of use leading to clinically significant impairment and distress. We know that substance use affects the brain structure and function with effect on neurotransmitters like other mental health disorders, and that there is a progressive impact on brain reward, motivation, and memory circuitry. I often explain to students what begins for one reason continues for another. So the best practice approach to assessment of substance use supported by SAMHSA and NIH National Institute of Drug Abuse is SBIRT. Screening, brief intervention, and referral to treatment. The SBIRT approach does not require a specific evidence-based screening, just that we use one. So some of them are listed on this slide. The CRAFT questionnaire is used primarily with the adolescent and young adult population. ASSIST is a screening test that looks for alcohol, smoking, and substance involvement. CAGE can be adapted to include drug use. And the audit is looking to identify alcohol use disorders. The evidence supports single question screening for illicit drug use, any number other than 0, to the question, how many times in the last year have you used an illegal drug or prescription medication for non-medical reasons, is a positive screen. And that single screening question was 100% sensitive and 73% specific for the detection of a drug use disorder. It's also very important to recognize that many who have substance use disorder, depression, and anxiety may have a history of trauma. Recent data indicate that 1 in 4 children and adolescents in the US experience at least one potentially traumatic event before the age of 16. ACEs are associated with substance use, obesity, smoking, physical inactivity, depressed mood, and suicide attempts. We have an entire chapter of our text that delineates current assessments for abuse, neglect, and violence, and outlines the assessment for traumatic experiences, which we define as events that overwhelm a person's capability of coping. And as we learn more about trauma-informed care and how to implement a strength-based framework for assessment and management of mental health disorders, our hope is that this chapter will support early identification, the provision of individual and family support, and the provision of treatment to support safety and wellness. Evidence-based assessment includes not only asking the history questions and doing the physical exam, but also an empathetic approach to the H&P. What we know is that our words and actions have the power to communicate that we care and that people are not alone. Incorporating mental health assessment into all assessments supports early diagnosis and treatment for mental health disorders and communicates that recovery is possible. This approach supports individuals to achieve wellness. And now, Burn Millick is going to review how we extend this important emphasis on wellness assessment to ourselves as clinicians.
Absolutely. Thanks, Alex. So we wanted to capture an entire chapter on the health and well-being of clinicians. Because if we are not well ourselves, we are not going to be able to deliver the best evidence-based care to others, nor deliver great care to our families. In 2017, the National Academy of Medicine set rates of clinician burnout and depression are at an all-time high, with suicide being on the rise, which gets back to Alice's point. We need to do great evidence-based mental health assessments on everyone. If you did not see the current issue of worldviews on evidence-based nursing, I encourage you to go to the journal's website. I edit that journal, and this whole February edition is focused on clinician and learner burnout and depression. There is the first study, longitudinal study of nurse suicide in that themed issue by my colleague Judy Davidson. There are also wonderful articles that capture studies of preventive interventions. 52% of clinicians are burnt out across the United States. The causes of burnout and distress in nurses and healthcare professionals are largely because of glitches in our healthcare system. Increased clinical demands, decreased control, role ambiguity, reimbursement issues. The majority of us came into this profession because we got so much joy out of caring for people. There's a problem when now clinicians only spend 25% of their time doing what they love, and that's caring for patients. There is absolutely a problem when a clinician has to give 12 clicks in the electronic medical record to give a flu shot. So the National Academy of Medicine said, we urgently must do something about this problem. So in 2017, they launched the National Action Collaborative on Clinician Wellbeing and Resilience. If you are not familiar with this website, I highly encourage you to check it out. There is even a knowledge hub of best evidence to decrease clinician burnout and improve their well-being. I feel really blessed. I was one of 60-some leaders throughout the United States to be appointed to this action collaborative, working very diligently on solutions. On the NAM website, we have 2 case exemplars of model places that are really working hard with great outcomes. We've got to build wellness cultures within our healthcare systems and within our colleges, because our students are creating the foundation from which they will practice for the rest of their lives. If they do not do good self-care, if they aren't taught the best evidence-based strategies for how to optimize their well-being, nurse suicide is going to continue to rise. So another report, if you haven't seen it yet, that just came out by the National Academy of Medicine as part of this action collaborative work is taking action against clinician burnout, a systems approach to professional well-being. There are actually 6 recommendations that come out of this report. As part of my team's work on this particular issue, we just conducted a systematic review of evidence on interventions that particularly work to decrease burnout and improve clinician well-being. That study has just been accepted for publication with revisions and hopefully will be out soon. We know mindfulness works, gratitude practices daily work, deep breathing works, and cognitive behavior therapy and skills building works to improve well-being and decrease stress, anxiety, and depression. Well, many of you also probably know that I've developed a cognitive behavior therapy-based intervention for children, teens, and young adults who are depressed, stressed, or anxious. In the literature and in all my studies, it's called Coupee. We adapted this particular CBT program for new nurse residents. We just completed a wonderful clinical trial that showed nurses who were taught this 8-session CBT-based program had less depression, stress, and a higher job satisfaction 6 months after completing the program. So again, we want to teach these CBT skills to all our students and all of our clinicians. And what is central in CBT is teaching people how they think directly relates to how they feel and how they behave. So self-care is necessary for safe and great care of others, but it is rare to find chapters devoted to self-care and optimal well-being for ourselves. We felt it was critical to include this type of chapter in our evidence-based physical exam book. We are told when we get on an airplane, if those masks drop, put the mask on yourself first before you put it on others. Nurses do a great job caring for everybody else, but we often don't do a good job of caring for ourselves. We published a national study of nearly 1,800 practicing nurses from 19 healthcare systems across the country. We found almost 23% reported depression, which is higher than the general population. And depression was the leading cause of medical errors. So again, we must do a better job at creating wellness cultures, providing evidence-based assessments and interventions for our nurses and our nursing students. If I could share one evidence-based slide with everybody across the United States, this is the one that I would share. 1 out of 2 people in this country have a chronic condition, yet 80% of chronic disease is preventable with just these healthy lifestyle behaviors. Physical activity, 30 minutes, 5 days a week, eating healthy. Many times when clinicians and others are depressed, stressed, or anxious, we emotionally overeat or eat in unhealthy ways. We need to all be eating 5 fruits and veggies a day. Don't smoke. And if we don't drink alcohol, don't start. But if we do, the evidence-based recommendation is limited to 1 drink a day for women, 2 drinks a day for men. Everybody then asks me, Bern, how big can that drink be? And I tell everybody, not the size of the alcoholic beverages they give us in Vegas. In our book, in this chapter, there are phenomenal tools, actually screening tools for clinicians, so they can assess their own levels of well-being, as well as depression, anxiety, and burnout. What finishes the chapter are excerpts from my multiple columns in the American Nurse today on how to enhance well-being along the 9 dimensions of wellness. So as I conclude the webinar for us, I want you today to say, today is January 1. I'm going to set a goal for the next 30 to 60 days to get just a little bit better at one of those healthy lifestyle behaviors that I just mentioned. I'd like you to write it down, put it where you can see it every day, because it takes 30 to 60 days to make a behavior change. I was 15 years of age, home alone with my mom when she sneezed and stroked out and died right in front of me. There was no counseling, no help for me in my little rural Appalachian town of Republic, Pennsylvania. But what was really sad about my mom's story, she had a history of headaches. For over a year, my dad would say, go to the doctor, figure out what's wrong. She went to her family physician 1 week before she died, was diagnosed with high blood pressure, given a prescription for a blood pressure medication that my dad found in her purse after she died. This is one of the reasons why I'm so passionate about wellness, great evidence-based assessment, and management. We must shift our current healthcare paradigm from one of crisis to prevention. If we do better evidence-based assessments, evidence-based management, we will decrease chronic disease throughout the United States and yield a healthier population. We will reach the quadruple aim in healthcare. I didn't have a mom to see me graduate from high school, college, go on to have my beautiful 3 daughters, 2 little grandsons and 2 character building pugs that I have today. So I'd just like to end by saying, if you can't prioritize your own self-care today in a better way for yourself, do it for your children, do it for your loved ones that want you to be around for a very long time. With that, we will open it up and take any questions from those in attendance.
Thank you so much, Bern, Kate, and Alice for that enlightening and inspiring presentation. It was fantastic. We do have a few questions that I'd like to highlight. So the first is whether we'll be sharing these slides. And yes, the webinar has been recorded and we will distribute it to all attendees afterward. And second, an attendee has inquired whether your textbook includes any instructor resources.
Yes, we actually have many instructor resources. So we have videos that we've done specifically of patient cases. So we have one that is in addition to almost every single chapter. We also have in every chapter as well, we have case studies. We have PowerPoints available. We have essay questions, test questions, all of the different and various ancillary materials that you would need in order to set up a course.
Excellent, thank you, Kate. And another question we have is on if you have any recommendations for key evidence-based resources or databases that faculty can share with their students and use in their teaching.
In our textbook, each chapter actually has its own evidence-based recommendations. So that's a complete different section where for that specific chapter, there's a list of resources available.
I would add to that, this is Alice Steele, I would add to that that typically what you're going to see are those large national guidelines like the United States Preventive Services Task Force or from the Choosing Wisely campaign. But we put them in each chapter so it would guide people to know, related to, for example, respiratory illnesses or assessment related to heart disease. So yeah, they're in each chapter.
Excellent, thank you. And we have another question on what role does financial stress play in self-care for nurses?
It's a big one. This is Bern. So in that last chapter on clinician well-being, I have as one of the sections on financial wellness. Because again, we look at wellness in 9 different dimensions, and not everybody's going to be in the same place. So it's really critical that we consider all of those 9 dimensions, and there are evidence-based tips for enhancing each one of those dimensions in our chapter. Whether students and nurses in practice look at our book or not, I honestly would like to make that clinician well-being chapter available to everybody, because everybody needs to be familiar with those dimensions, familiar with the screens, the evidence-based tips, and the resources that are available.
Great, thank you, Bern. And we have reached our time, so thank you everyone for joining us today. And as you can see on the screen, the contact information for the presenters is available, and it'll be available in the version that we send you, the recorded version. So thank you so much. And we do have some feedback from a panelist who is thanking you. This was one of the most informative webinars I have attended. You are all amazing. So that's some pretty good feedback and a great way to end. So thank you, everyone, and I hope you have a wonderful weekend.